little bit off script because we happen to get a particularly good speaker. So we are going to have 3 presentations today. We'll first be hearing from Professor Jeroen Hendriks, who is going to be our guest speaker for the day, and I'll just introduce him in a second. But the other 2 sessions we'll be having today will be Katie Nesbitt, who is going to be our Service of the Month person for July, and she'll be talking about Catch Web. And then we'll finish off the session with our pharmacy corner with Lemlem, who will be talking about beta blockers for acute MI. So I will get us started with a quick introduction of Jeroen. We're still getting a few people come in, but we'll get the ball rolling because I know we've only got 45 minutes of your time. So welcome everybody. We'll introduce Professor, oh, sorry. No, you are a professor, aren't you? Yes, okay. So and in fact, Jeroen holds the inaugural professorship of cardiovascular health, which is a joint position between Flinders University and Carlin. So he is a professor at Flinders University and also with the Royal Adelaide Hospital, and he's going to talk about integrated care. And I'll get him to introduce his talk. He'll know much better than I do. And I will hand you over now. Jeroen, you can have the floor.
Thank you very much, Stephanie, for your kind introduction. I'm going to share my screen, and I hope you can see my slides now. All good? Yes, thumbs up. Perfect. So thank you very much for the kind invitation to present as well. I have taken the liberty to change my title a little bit, because I think it's also interesting to talk about integrated care, which is actually my focus area in research, but also in practice, and how risk factor modification is aligned with that. And then I'll talk a little bit about the nurse-led clinic that we're running here as well. Now, a little bit about atrial fibrillation, just to set the scene. Maybe you all know this, but it might be good to just repeat that. So atrial fibrillation is considered the most prevalent cardiac arrhythmia. And in 2016, there were about 44 million individuals affected with AF globally. The management of AF can be quite complex, and it requires a systematic approach. And currently, it is also seen as the most common cause of cardiovascular hospitalization. So, and that is shown in this figure here. This is data from Celine Gallagher, who looked into hospitalization in Australia over a 21-year period of time. And here, atrial fibrillation-related hospitalization is represented by the blue bars. And what we can see is over time, there's a steep increase of AF-related hospitalization, but currently outnumbering hospitalization for important conditions such as myocardial infarction and heart failure. And given that hospitalization for AF is the main cost driver, you will not be surprised that this goes hand in hand with an increased cost for the healthcare system. So actually, the question that we need to answer is, are our current models still suitable to provide the required care, or do we need to explore novel models of care? And we've been looking into integrated care, which has been identified as a suitable approach to manage patients with chronic conditions. And what it actually is or does is a worldwide health reform and implementation of novel models of care to prevent fragmentation of care that we see now in the current models very often. So the aim of integrated care is to improve access and quality of services, and on the other hand, also to improve efficiency and outcomes of care. Now, the World Health Organization has provided a definition on integrated care, but that is, to me, quite a long and difficult to understand definition, I would say. So I just made it a little bit shorter to the extent that I think that is really important, and that is bringing together, a concept bringing together inputs, delivery, management, and organization of services across the continuum of care. And I think across the continuum of care is really important here, because it's not like one visit, but we talk about chronic conditions here. And this is also reflected in the figure, where we see a patient with a chronic condition in the center of the care delivery, with the care delivered with the care organized around the patient, making use of coordinated health services, team-based care approaches, and also technology is more and more important in this field. Now, we do have guidelines in Australia on the diagnosis and management of atrial fibrillation. They're from 2018, and the European Society of Cardiology actually updated their 2016 guidelines last year. So that's why I'm focusing on the most updated guidelines, and that are the ESC ones. And they refer to integrated care as this approach. And I think what is very much important to remember is that there's four main fundamentals within integrated care that need to be present. So first of all, there's active patient involvement and focusing on a patient-centered approach. As we can see here, patient on top of the figure, where we need to really focus on preparing patients and educating them to undertake self-management with a focus on their treatment, their adherence, but also on risk factor management and lifestyle modification. On the other hand, we also need to make sure that our healthcare professionals know how to work within an integrated care approach. So very much important as well. Then the second fundamental is that the care is delivered by a multidisciplinary team. So it's no longer one healthcare professional like a cardiologist or a general practitioner, but it's really working in a collaborative model with cardiologists, nurses, allied professionals to really make this integration work. The third fundamental is that there is a comprehensive treatment approach, and this goes beyond the management of atrial fibrillation alone. So AF is managed by a rate control strategy or a rhythm control strategy. But we also need to be aware that patients with AF have a high risk of stroke that needs to be prevented. And of course, it goes hand in hand with underlying cardiovascular conditions and risk factors. And then finally, technology, really technology to support healthcare professionals during follow-up, for example, but also patients to promote their medication adherence, but also to guide them in their lifestyle modification. And I would like to just briefly touch on these four elements. So within a patient-centered approach, what is really important is to start with engaging with the patient, to really understand what the patient wants, what the patient needs, and what their preferences and values are. And based on that, we could align that with the recommendations from the guidelines to make the treatment as tailored as possible. Then next, of course, education and instruction. Patients need to understand what is their condition about and why, for example, do risk factors lead to worsening of atrial fibrillation, and how we as healthcare professionals can contribute to that, but also how a patient can contribute to that and improve the outcomes of their treatment. And then finally, empowerment, really preparing patients to undertake self-management, because it's there where when they go home, that's where the treatment starts, actually. So we can only provide them with medication, for example, or do a procedure, but patients need to be adhering to that in their home situation. So as you can see, I always call it the 3 E's: engagement, education, and empowerment. Very much important. And if we can get this focus on this, we also, in the ultimate situation, can patients get involved in informed and shared decision-making. Then the treatment by a multidisciplinary team. If we look at the figure, we can see already a patient-centered approach, the patient in the middle, with around the patient in this outer circle, those specialists that may be involved in an individual patient and in the treatment of this patient. This can be, for example, the heart failure team, it can be a neurologist, it can be a dietitian, but it might not be the case in every patient, because not every patient needs the same care. Then directly around the patient, there's a core team collaborating, but also collaborating with the patient, and this consists of a cardiologist or an electrophysiologist, an AF nurse, the family or the carer of the patient, and in some cases also the general practitioner or a pharmacist, to really provide this comprehensive treatment approach. And this is steered by technology, and I'll talk about that in one of the next slides. Here we go. Technology. So technology is there to really, screen for atrial fibrillation, to monitor atrial fibrillation. So we have PPG technology, we have ECG in watches or in handheld devices, and we also have like Holter monitoring in the traditional way or implantable cardiac monitors. There's also decision support technology to really support healthcare professionals to navigate through the care process. So these systems are based on the evidence-based guidelines and based on the information provided about the patient. Think about their symptoms or their medical history or the results of their diagnostic tests. There will be guidance from the system saying, look, based on the information, you should go for a rate control strategy, or the patient is at high risk for a stroke. You need to provide them with anticoagulation. But there's also apps available to guide patients in their self-management, to educate them on demand and give them some guidance in their home situation. And then finally, a comprehensive treatment approach. I just mentioned it all, but now the guidelines, the ESC guidelines 2020 say as easy as ABC. Well, A refers to anticoagulation to avoid strokes. So here it is really important to identify truly low-risk patients. So these patients are not at risk for a stroke and they don't need anticoagulation. But on the other hand, if the CHA2DS2-VASc score, that is a score that we really determine the risk with, if that is elevated, then we need to determine if the patients require anticoagulation and which anticoagulant would fit best for the individual patient. B refers to better symptom control. So it's important to assess symptoms and to look into quality of life and then determine a rate or rhythm control strategy. But also patient preferences here are really important. And then finally, looking into the C component, which refers to comorbidities and underlying cardiovascular conditions and risk factors, such as hypertension, diabetes, but also obesity, and these kind of risk factors are really important to be addressed. Now, I'm also affiliated with the Center for Heart Rhythm Disorders that sits within the University of Adelaide, where we actually looked intensively in managing risk factors in patients with atrial fibrillation. And what we saw is that if we address these risk factors and we try to reduce them, there will be mechanistic changes in the heart, which leads to a lower burden of atrial fibrillation. So patients will have less occurrences of atrial fibrillation. Now, I've put this slide in because I think it's very interesting to see how the global increase of obesity globally has been in the last 40 years. So this is data from the Non-Communicable Diseases Risk Factor Collaboration, and they collected data on obesity globally. And I'll start the video now, and you can see it starts from 1975 and it counts up 40 years. Remember that the BMI is defined here as 30 or higher, and the darker the color, the higher the prevalence of obesity. And as you can see, the years are counting, and you can see that the colors are really changing. And just focus on the US when we cross the millennium. That is dark red colored, but also focus on Australia, where we also have a dark red color. Now, 2014 is the last year. And if we look at that, we can see actually that 75% approximately of the global population has a high prevalence of obesity, which is really an increasing factor and of increasing importance to address that. So back to the risk factor clinic that I just referred to. So what we've done there is really patients with atrial fibrillation were referred to this specialized risk factor clinic. This was first driven by a cardiologist, but currently that is driven by a nurse, where we address all these risk factors. But this starts by getting to know the patient. So really engaging with the patient, having a conversation and see, well, what do you think are your risk factors? But also asking the patients to maintain a lifestyle diary regarding their dietary intakes, but also their exercise. And based on that, we try to educate patients, provide them with a diet plan, try to get them involved in exercise, in the beginning, approximately 30 minutes, if that's possible for the patients, for 3 to 4 times per week, and increase that to up to 250 minutes per week. All the other risk factors are diagnosed, of course, and managed with lifestyle modification. But if that is not effective after a certain while, like let's say 3 months, then we added medication as well. Um, and this is an overview of the studies that have been performed, and it takes too much time to go into detail. But what is interesting, I think, is to look at these figures here, because with all the risk factor modification, we found that the burden of AF, including AF frequency, AF severity, the duration, and the severity of symptoms, is reducing, while patient global well-being is increasing. So that is really an important finding. I would like to show you one of the studies. This was one of the earlier studies that we've done, the ARREST AF study, aggressive risk factor management in patients with atrial fibrillation and their implications for the outcomes after an ablation procedure. So the hypothesis here was that late recurrence of atrial fibrillation after a procedure is due to the progression of the underlying substrate, and the underlying substrate is the risk factors. So therefore, aggressive risk factor management would lead to improved outcomes. So what we did is that the consecutive patients who were referred for their first AF ablation, we looked at patients with a BMI of 27 and higher and at least one risk factor, and these patients were offered aggressive risk factor management. If patients accepted that, they formed the risk factor management group, and if they refused, they were the control group. So these patients got some information, but not this intensive follow-up as we did with these patients. So some of the results of this, so after 2 years follow-up, we can look into the impact on risk factors. So the gray bars here represent the control group. The orange bars represent the risk factor management group. And what you can see is that over 2 years, after 2 years follow-up, there's a significant reduction in weight in those patients in the risk factor management group. And this is, I think, is the most difficult risk factor to address. And this went hand in hand with significant improvement of glycemic control as well. Looking at sleep apnea, the number of patients with sleep apnea reduced remarkably between groups, and also looking at blood pressure management over time, that improved in both groups, but again, it was significantly better in those patients in the risk factor management group. Now, the primary endpoint of this study was to look at AF-free survival. So that means that, that we were hoping that patients remained in sinus rhythm after their ablation procedure. And we see that here in the Kaplan-Meier curve. So this is the result for the success after one single ablation procedure. And you can see in the control group, there's attrition. So only 26% was in sinus rhythm after the follow-up. But 62% of patients after one ablation procedure were still in sinus rhythm after the follow-up. And the same trend we see in those patients who had multiple procedures. Again, a large proportion of patients in the risk factor management group were in sinus rhythm compared to those in usual care. Now, bringing that back to the integrated care again. So we're now, this is the study we're running now is the iCare AF clinic or study, integrated care for AF, where we apply this in a rapid access AF outpatient clinic, where we integrate specific AF management and risk factor management. And all the elements or the fundamentals, I should say, from integrated care are present. So it's a multidisciplinary team, but it's steered by a nurse. It is patient-centered. We need to have our patients on board. So the 3 E's, engagement, education, empowerment, to focus on their self-management and their risk factors. Technology to support this approach. And of course, again, the comprehensive treatment with a real focus on risk factor management and lifestyle modification. Now, in this approach, we use decision support technology that is built in our database that we're using. So this is the research database, but also a clinical database. And really based on the guidelines and based on the information that we enter about our patients, the healthcare professional together with the patients is guided in the decision making. On the other hand, we want to, I just said, patient involvement is really important. So we developed an app that patients in the intervention group are provided with. And this app provides the patient with information on atrial fibrillation. So what is it? How does it feel? What are my risk factors? What do I need to do for that to keep healthy, for example? We also have little videos to show what is the difference between atrial fibrillation and sinus rhythm, how does a stroke occur, and so on and so on. But we also want the patient to work with the app. So we have an area on lifestyle factors. So we ask patients to list everything they do on lifestyle. So that can be their food diary. What do you eat on a day? How does your lunch look like? What does your dinner look like? But also their exercise. Is it cycling, running, swimming, whatever it is? How long do you do that? Do you have any symptoms during the exercise? Let's say the patient says, yes, I had palpitations. How bad was that? Was it moderate or was it mild or very severe? And so on and so on. And this is really this data. We use that in the clinic to work with the patient, but also this is to keep patients involved in their own care process. So we're running actually this clinic, which is a large randomized controlled trial. We have now set it up at the Royal Adelaide Hospital, but we're planning to move, around in the hospitals. No, not move around, disseminate this into and implement this in the other hospitals in the state and also go interstate. So I'm happy to keep you updated on that. But just to conclude, I think given the increasing prevalence of patients with atrial fibrillation and the fact that they are all affected with comorbidities, I think integrated care is an emerging approach to provide multidisciplinary and comprehensive care. Risk factor modification is a fundamental aspect of this care, which really requires a systematic and tailored approach and follow-up. Providing a personalized care approach and really working individually with the patients, having them on board is crucial. The 3 E's, again, I just mentioned that: engagement, education, and empowerment. Of course, technology to really support and the healthcare professionals and the patients is really important. We have some research that has demonstrated potential value of integrated care as well as risk factor management, but I think we need more research to really provide additional evidence also how this works here in Australia. Thank you very much for your attention, and I'm happy to take questions.
So if you want to stop sharing your screen,
yes.
And we can see the group. So I will open it up to the group if they have any questions, and if not, I definitely do. So does anyone have any particular questions for Jeroen? No, so I will ask mine. So, yeah, we do. Yes.
I just want to know how you do so well with the weight loss, because it does seem to be that that's the risk factor that most needs addressing. And so when we do the cardiac rehab, that's the trickiest area to sort of combat. And I think we feel like we don't want to judge or fat shame or, put too much pressure on the patients for risk of losing rapport. So any tips or suggestions on that would be good.
Yeah, so I'm completely with you there, because it's a very, very tricky and difficult risk factor to address, and also to keep patients on board there. So referring to the study that I just showed, RSAF, this was around like getting an ablation. So patients were of course educated, but also told, look, if you can lose weight, there's a chance that your other risk factors will be affected as well, and that decreases, and there will be it's very likely that you remain in sinus rhythm. Remember, these were symptomatic patients, so if you have really severe symptoms, then there's an extra trigger to work on that. And I must say, so they really worked then with meal plans and exercise programs provided by an exercise specialist. So it was really, really strict and aggressive. So I think that led to these results.
Yeah, good motivator, because it's a very clear, defined motivation rather than being an amorphous, you'll do better. you will have a better success with this surgery. Yeah, okay. Thank you for that. That's really interesting.
And maybe to add to that, I think it's really important that we try to work with the patient in a way of that it really comes from them. So after the first visit, they should say to us like, yeah, that's right, I need to work on this, instead of we saying, you go home now and, next time you lose 5 kilos or so. That doesn't work, that is, but if there's this real trigger behind that, I think that's really, really important. Yeah.
Great. Thank you.
Thanks.
Were there any other questions from the room or from the, so Lemlem, did you have a question? Yep, I'll put my mic on.
Wait, I think you're muted.
What about now?
Yeah, that's better. That's better.
Yeah, so it was really good presentation. Thank you for for the great presentation. My question is, like you said, it's really extensive and it needs lots of resource from different disciplinary areas. How do you think it will be translatable to wider or national or international? Yeah.
Well, I think that's why we're running the iCare AF trial now. So the risk factor clinic was like standalone, so to say. So now we try to get everything on board within the iCare AF clinic. It is intensive, so the nurse has, for example, an hour to work with the patients. But I think, once I always say it's like having children and to learn them to cross the street. In the beginning, you keep their hands, and you teach them like look right, left, and these kind of things. And there's a moment that you can let them go. And that's the same here, so you let them go. And then, after like a while, you need to get them back to say like, how are you going actually? And I think that is the thing we're trying to figure out now, what will be the best modus and how to also, refer patients then from this iCare AF clinic to general practitioners, for example, because those patients who are really stable don't need to be seen in the hospital, but we can have an integrated approach, an extended integrated approach, I would say, in GP services. But that is the next step, I would say.
Thank you.
Thank you.
I'll get you to turn your, lovely. Thank you very much, Jeroen. So we'll move on because we'll have Katie next. But if you did have any extra questions that you didn't get a chance to ask, I think it would be fine if you wanted to send me an email and I can pass that on to Jeroen to get in contact with him.
Yeah, absolutely.
All right.
Thank you.
There we go. Fantastic. Okay, so now we'll move on to Katie. So I'm going to share my screen and Katie's going to be our service of the month for July, and she'll be talking about the service of Catch Web. There we go. Now, can you see that all right, Katie?
Yes, I can.
Fabulous. Now I'm just turning it into a slideshow. I think I'm turning it into a slideshow. There we go. Lovely. Okay, so I have some specific questions that I'm going to ask Katie. So this is another way, if you are the service of the month, we had a fantastic presentation last month, which was very driven by Caroline. But if this works better for you, this is another mode that we're offering. And so I'm going to ask direct questions to Katie. And we have some slides just to provide some more information in the background. So feel free, if this is works better for you in your service, please let me know and I can do the question asking process. So Katie, who are you? Who is CHAP?
Well, if we start with who am I, obviously I'm Katie. I'm a registered nurse. I'm still working in clinical practice in the Limestone Coast local health network and doing my PhD full-time in the CHAP project. And my role has been the development of the Catch Web that we have just launched. So do you want me to talk about Catch Web here?
Yep.
So
so
we're multidisciplinary, so it's a really exciting team to be a part of. So we've got nurses, medical officer, pharmacist, health scientist, social worker. Yeah, so it's a really good team that brings a great perspective to what we're doing.
Yeah. And what does CatchWeb do?
So CatchWeb's focus and objective is to provide people who are referred into, need to do a cardiac rehabilitation program, just a third option to do that. So obviously at the moment people can do face-to-face or telephone, and those services are effective and fantastic. But we are wanting people, particularly living in country at the moment, but certainly everybody into the future, to be able to have that choice of doing a remote cardiac rehabilitation program or having a hybrid program, whether it's through face-to-face web, telephone web, or even through their GP, to hopefully increase people's participation and completion of their program.
And what sort of people might be joining CatchWeb?
So for the next 12 months, it's going to be those that live in rural, remote, regional South Australia, but into the future, really anybody. And I guess we know that probably the group that will probably be most interested and keen to use it will be those who are still working, women, definitely, with other, juggling commitments, both of work and family, but certainly a significant roadblock to people completing their program is their return to work and the commitments that brings. So, and we certainly evolving generation of more IT savvy people. So it's definitely going to suit that younger person or that person going back to work.
Yeah, and what's your role going to be in the delivery of the CatchWeb service?
So for the next 12 months, my role is as the web manager, and it's a role that really is to just see the smooth running as we launch and roll out the website and evolve it and have patients included or choosing to use that option. So clinicians will be looking after those patients, but my job's really just to oversee that and liaise with clinicians if they're having issues with the system or suggestions as how we can improve things, and really just supporting them as they learn how to use the system.
Mm-hmm. And what are some of the benefits of the CatchWeb delivery process?
Well, to begin with, I think the most important benefit is that we know that we've co-designed with patients themselves, so people that have done a cardiac rehabilitation program. And like Jeroen was saying earlier, this patient-centered, human-centered, people-focused approach is really important. So a lot of the way the website's set out has been influenced by the feedback we got at our co-design workshops. And I think the other important thing to mention is, in terms of benefits, is the content has been based on the national quality indicators and a pathway to cardiac recovery as outlined by the Heart Foundation. So it's really uniform, standardised and clinically based information.
And one last question, how do you think the CatchWeb service could be of use in future lockdowns?
Oh, brilliant. It will be amazing. And I think we'll only, see how useful it is over time, because I guess that is where, for people who are in a face-to-face service and really happy and comfortable in that and doing well, but as we've seen, services have been disrupted or stopped, it will allow them to pivot really quickly, still under that same clinician's care, but accessing their program and being able to complete their program and have their follow-up assessments without there being too much, the only disruption being that they can't attend their face-to-face, but they don't lose that contact and continuity with their clinician or with their program.
Fantastic. Thank you, Katie. That gives a beautiful overview of CatchWeb. Did anyone have any questions about the CatchWeb service? That while you've got Katie as a captive audience. Yep. So I'll pass over to Lemlem. Let me just, I don't know whether I can mute myself. Okay.
Hello. Yeah, thank you very much, Katie, for the presentation or the service of the month. My question is, like you said, all the evidence are, I mean, they're up to date and it's according to the recommendation of the HAB Foundation and with lots of evidence-based information. Do you think any public person or anyone who is not referred by the physicians or any other route can access this resource?
No, I have to pass on that because I'm not sure. So usually referral is through a nurse, cardiologist, doctor, physio. One of the Catch team might be able to tell us if there's a self-referral process, because if there is a self-referral, then yes, they can, because they will be referred, they will come in through the Catch system, and then their referral pathway goes from there. So I can hand that question back to if there's any Catch people on board, as if self-referral is a process.
Yeah, so like you said, Katie, certainly there is a self-referral pathway. As long as the patient or their family member met the criteria for cardiac rehab, and we'd be pretty generous with that. I mean, if someone is keen to do cardiac rehab, we want them to do it. So as long as they meet the criteria in some way, we could then refer them and they could be put on. So yeah, there's no, you don't need a doctor, you don't need a nurse to do it. Obviously, you know, normally for a Catch patient, we would then chase some correspondence from their GP or cardiologist so that we had some, you know, facts to deal with. Like,
so the clinician is familiar with the case, and we would probably follow that before we, you know, saw the referral through. And
But yeah, certainly self-referral is fine.
Thank you, Gemma.
Thank you.
All right, now we'll move on and do the last section because I've seen Lemlem's slides and they're meaty. So moving over to the next section, and I am just going to mute me and put the thing in so that you can speak. There we go. Go ahead, Lemlem.
Yep. Thank you very much. So this month's presentation is about beta blockers, mainly on the duration, how long is the duration which is recommended for acute myocardial infarction patients. Next slide. So before we go to the medications, it's good to have an overview of what AMI is. Obviously, you all know it, so I will just say some points. So myocardial infarction is a stressful response of the cardiac muscles, which will lead to activation of the sympathetic system, to pain, anxiety, and reduction of cardiac output. And activation of the system will cause lots of negative consequences, like increased consumption of oxygen and demand, which will expand the infarct size and formation. And it also causes ventricular fibrillation threshold reduction, which will also cause sudden cardiac death, or on long term, it will also cause cardiac remodeling and heart failure. So the mechanism of action of beta blockers, as you may know, is they are beta blockers. That means they block the beta adrenergic receptor of the sympathetic system. And by blocking this system, they will reduce the damage on the heart by reducing oxygen consumption and demand, which will lead to reduction of heart rate, blood pressure, contractility, and also cause relief of ischemic chest pain. And this reduction in heart rate will also prolong the diastolic system, which will improve the coronary cardiac perfusion, and which will also cause ventricular fibrillation risk of reduction, which will also reduce the risk of sudden cardiac death. So continuing with the mechanism by blocking this sympathetic beta blockers, they will reduce the rate of coronary arteriosclerosis in MI and non-MI patients, which will lead to the progression of low risk, and it reduces the infarct size and early mortality, especially if it's started early within 24 hours of diagnosis. And it also causes reduction of the long-term, it will reduce the maladaptive remodeling and heart failure, which was caused by the long-term sympathetic activation. And in addition to that, the beta blockers also inhibit platelet aggregation and thromboxane synthesis, which will have very good effect on the cardiovascular risk prevention. So for patients who doesn't have any contraindication to beta blockers, it's recommended that they should be started within 24 hours of diagnosis. And mostly the cardioselective drugs are the preferred ones, because the beta blockers, we have 3 receptors, beta 1, beta 2, and beta 3. Beta 1 is a receptor which acts mainly on the cardiac system, and beta 2 acts on the pulmonary and other parts of the body. And blocking all the beta receptors will have more adverse effects. So for the purpose of MI treatment or cardiovascular system, it's recommended to prescribe the cardioselective ones, the beta blockers. And at the start of the treatment, it's also suggested or strongly recommended to start with the short-acting beta blockers, because we don't know the exact dosage for the particular patient. So it's good to start with short-acting till we adjust the right dose for the right patient to get the right response. Mostly the oral beta blockers are the recommended ones, as I said, because of easy to take and also highly preferred by patients. But in case of complicated patients, like patients with hypertension plus AMI, intravenous drugs can also be, or beta blockers can be recommended. So coming to the duration, how long is long therapy? It depends. For AMI patients, after they have been diagnosed with AMI, it is recommended strongly to be taken for up to 3 years, and they should be discontinued gradually, because the rapid withdrawal of these beta blockers will have their own impact or cause overwhelming effect of the sympathetic system. And this is derived from randomized controlled trials, which has shown that beta blockers, when they are taken for longer than 3 years, they don't have any significant effect on the all-cause mortality, but they have maximum effect in the first duration of the treatment, the first year of treatment, which will cause reduction of all-cause mortality. And after the patients are adjusted on the right medication or the right dose, it is suggested for long treatment, they should be taken the once daily medications are the more preferred ones to enhance adherence to medications. And patients who are on lots of high risk features like the cardiogenic shock, heart failure, or chronic kidney disease, these beta blockers are recommended to be used indefinitely. So as all medications, beta blockers have their own adverse effects. And the most common ones are the sympathetic bradycardia and hypotension. And they can also have an effect on acute decompensated heart failure as a side effect because of the blocking of the sympathetic system. And heart block is also another adverse effect. And depression, fatigue, sexual dysfunction, hyperkalemia, weight gain are also most of the adverse effects of this medication, mostly because of the mechanism of action of these drugs and the physicochemical property of the medication, especially the central nervous system adverse effects like depression. They are caused by drugs which have high lipid solubility. But in case if patients are having this adverse effect, switching them to low lipid soluble drugs like atenolol will be a suggestion. And the other side effect of beta blockers is the beta blocker withdrawal, which will lead to rebound effects, which will increase the sympathetic activity because of the upregulation of the receptors. So it is strongly suggested that when beta blockers are planned to be stopped, it should be done gradually. And there are some contraindications or conditions where beta blockers should not be prescribed, especially in hemodynamic unstable patients, patients who are not stable hemodynamically. Beta blockers should not be prescribed, or patients with severe decompensated heart failure or cardiogenic shock. Patients should not be given beta blockers. Patients with active bronchospasm, they should not be given because of the adverse effects I said. Especially when they are given in higher dose, they have the activity of blocking all the beta receptors. So blocking beta receptors especially will cause bronchospasm, which will aggravate the condition of active bronchospasm or other pulmonary disorders. And heart block, heart failure, also another contraindication, especially at the start. If the patient has a heart failure, beta blockers should not be started. This patient should be stabilized on other medications until the heart failure is controlled, and then beta blockers can be started after that. And diabetes, the evidence is that the beta blockers can be used, but patients should be educated or aware that these drugs can mask the hypoglycemic symptoms. So patients should be advised to regulate their glucose level frequently so that they know that they are at risk or the blood glucose level is not controlled well or to act properly. But at the moment, the beta blockers, they can be given with preconditions or precautious prescription. In mild to moderate COPD or asthma, like I said, they can be given, but in severe case, it should be contraindicated. And the other issue that should be focused is with beta blockers and other medications, all the patients who have cardiovascular disorder like MI patients, they are also taking other lots of medications. So it's good to keep an eye on the drug-drug interaction when these medications are prescribed. And that's all. Thank you very much.
Okay, so I'll just take back the chair. So we've sort of run out of time, so no questions for Lemlem today, but do feel free to send through any questions via email, and she had her email on the first slide. And so I will just wrap up the session very quickly to say we are having a public seminar and it's going to be filled. So if you want to ask the hard questions, here's the chance to do it in a public seminar. I would also like to say that the chat CPD page on our website has been updated, so go and check that out. We have our program up for the rest of this year and next year, subject to change, of course, if something happens with our speakers, but check ahead and see what our interesting presentations are going to be. And then lastly, I will just end to say that we are going to do a more involved evaluation of the CPD sessions. And so at the end, after this session, I'll send everyone an email with a link to a 6-question survey. And if you've enjoyed the presentation or if you have some suggestions on how our presentations could be better, please feel free to click on that link and respond to our questions about our sessions. And it's all anonymous, and all of this will help us make sure that we deliver sessions that are going to be helpful to you. But that is everything for today. Thank you very much for joining us for our July CPD sessions, and we'll see you again next month with a super interesting presentation and a new speaker. Thanks very much, guys. See ya.